There we go, continue. Now, for those of you who could make our inaugural event at the start of this year or are new to us, we are the Scottish branch of Psychologists for Social Change. So we are a group, a network, I should say, of psychologists from around Scotland. And we're interested in applying psychology to policy and social action. We include academics, practitioners, and students from across Scotland at different career stages, and importantly, across different disciplines. So kind of broadly, we aim to apply psychological knowledge in the service of social change. And this could be through publicising, advocating, and actively working with organisations. And the kind of values that we have are particularly true for the field of medicine, which will be kind of the focus of this talk. I was really lucky enough to study medical education for my dissertation. And what I really noted is that considering medicine is the study of the human body, quite often it misses out on the human, which hopefully psychology can come in there. Where are we, sorry. Yeah, and I often describe psychology research as a bit like the curtain from the Wizard of Oz. You know, there's all this great stuff out there and all these great researchers, but it's in this bubble of academia. It doesn't, you know, go out in the broader world. And so when I was really lucky enough to get a guest lecturer from Dr. Liza Morton, I was really impressed by her values and how she embedded the research and those who were researched. And just as much as I enjoyed that lecture, I really hope you enjoy today's talk. So without further ado, please welcome Dr. Liza Morton on Healing Hearts and Minds.
Thank you, Cameron. Okay. So, hi, so I'd like to be here today. Thanks so much for inviting me, Cameron. So I am Liza Morton and I'm a counselling psychologist. And I'm going to talk to you today about psychologically informed medicine. Just try and change this. So this is just a brief overview of what I'm going to cover, and it's just going to be a really brief overview of all of this because there's a lot of content. So forgive me if I'm kind of running through things quite quickly. But first of all, I'm going to talk about my professional and health journey, and then what I've termed psychologically informed medicine, and the different parts of that, and the kind of facets that I've been building on, including hospital gown research, developing a measure of psychological safety, the impact of the pandemic on congenital heart disease and mental health, and then some activism work that I've been involved in, Ableism, and our Scarred for Life exhibition. So before I start, just to say, please do take care of yourself. I will be discussing medical trauma in children and adults in this talk, and this will be personal for some of you. So please do be aware of your own reactions and do what you need to do to take care of yourselves. So in terms of my professional journey, I am a chartered counselling psychologist. So over 20 years ago now, I studied psychology at the University of Stirling. And following that, I completed a PhD at the University of Glasgow with Professor Philippe Shins. I then did a postdoc for a year back in Stirling, and then I did the first year of the Clinical Associate of Applied Psychology Masters between Stirling and Dundee University. And I worked as a CAP for 10 years for NHS Fife. So I had a lot of experience there of working with mental health problems within primary care. And during that time, it was kind of part-time, so I also completed the independent route through the BPS and qualified as a counselling psychologist just over 5 years ago now. And I then left the NHS and set up an independent practice. And I'm also involved in some research projects, and I currently hold an affiliate post at the University of Glasgow, so sort of back where I started. So a kind of parallel journey has been my health journey. And I was born with 3rd degree heart block. So that means that the rhythm of my heart doesn't work. So I need a pacemaker. And I was actually fitted with an external pacemaker when I was 4 days old, and my first pacemaker when I was 11 days old. And this was a world first in a baby that small back in 1978 at the time. And this happened at York Hill Hospital in Glasgow. So since then, I've had countless interventions and hospital visits. Those early pacemakers were set at a fixed rate, so they were physically limiting. So I wasn't allowed to take part in gym or active play or dance lessons, horse riding, kind of normal parts of childhood. And by the age of 7, I'd had 5 of these pacemakers, so they were quite fickle back then, and they were fitted by thoracotomy, so they kind of broke open the ribs and put the pacemaker straight on the heart, so it was pretty big surgery. Prognosis was uncertain at that point because it was pioneering treatment, so they couldn't say you know, how long I would live. They couldn't tell my parents, and I faced lifelong psychosocial barriers. When I was 12, a hole in my heart was found and I required open heart surgery to fix that as well. And around about then I got my first newer pacemaker, which was variable rate, so that enabled more physical activity. And I was most recently fitted with my 11th pacemaker 2 years ago now, and I had to stay in the hospital for a month while I waited on the surgery required for that, because it's quite complicated and specialised when you've had so many devices. I've had countless issues with adult care provision, particularly in accident and emergency, and also during pregnancy. And while I've always lived as full a life as possible, I have felt a lack of psychological support. I was diagnosed with PTSD when I was about 17 years old, but there wasn't really any treatment back then in the sort of mid-90s for that. And I benefited from body psychotherapy as an adult, so when I was in my early 30s. So just to put this into historical context, like I said, heart block means that your heart beats very slowly. It can be first, second or third degree. So I have the worst kind, which is third degree. So basically my heart wouldn't beat itself at all without a pacemaker. And in children that can be congenital, or it can also sometimes be acquired after open heart surgery. Back in the 50s, they had the first treatment for this, but that involved a large external unit and a chest electrode, which basically kind of pumped sort of 150 volts onto the child's chest externally, which was very painful, caused skin blisters and limited mobility. So that obviously wasn't a solution, and it was only used for temporary heart block. Towards the end of the late 50s, they come up with pacing leads that they could actually implant straight onto the heart. And then that meant it was a sort of a much lower voltage, so there wasn't the same pain, but obviously there was the pain of surgery. But the battery was external. So you'll see this picture here of this little boy here in the late 50s, and he has an external battery there attached that he has to carry about with him. By the 60s, between the 60s and the 90s, they started to refine the pacemakers, and they got small enough batteries to fit them internally. And that's what I kind of benefited from, and I had the smallest, I had the first, was the youngest child to be fitted with that in 78. And I think it's important to note this kind of quote here, where in terms of the cardiology history, they said it became commonplace to put these new devices or even prototypes into clinical use immediately, then iron out the imperfections based on the clinical experience, because most of the patients were close to death anyway. So we were, in effect, guinea pigs. We were being fitted with the newest technology, but they didn't know if it would work, and they didn't know what the complications were. And you can see that from this abstract from the Thoracic Cardiovascular Surgery Journal in 1986. And the authors of this, Jameson was my surgeon, Brewster was the physicist who used to come out from Glasgow University to teach on me how to work the pacemakers. Bill Doig was my cardiologist, and Pollock, he was another surgeon. So these were my care team, and I am the 11-day-old, so the youngest baby in this particular abstract. And you can see that there was 26 infants, and by the time this was published, 7 of those infants had died. So this was really kind of pioneering work. So congenital heart disease is the most common birth defect. Around 1% of live births, there is a kind of anomaly with the heart. There are a wide range of different cardiac anomalies. So my condition is only one. There are many other conditions, and these vary in complexity. They vary in what surgery is required. And there's this growing population. So 90% of babies with a heart defect now survive into adulthood. Whereas back in the 1940s, only 20% did. So we've got this huge growing population. But there is no cure, and lifelong monitoring is recommended. And we live with an increased mortality and morbidity burden. And I've always been aware that the psychological impact is widely neglected, and we really do need a cultural shift from this survival focus in medicine to a holistic understanding. So this is where what I've termed psychologically informed medicine comes into it. So we know from the evidence base now that there is an increased risk of neurocognitive deficits in congenital heart disease. Between 12 to 31% of children who undergo cardiac surgery develop post-traumatic stress disorder. Almost 15% of mums and almost 10% of dads also do. So it affects the wider family. 21% of adults with a congenital heart condition develop PTSD, and that's compared to 3.5% in the general population. And 28% of adults have anxiety, compared with 17% of the general population, and 31% of adults have depression, compared with 11%. So I like this picture because I think it kind of sums up kind of what's going on here, and that sort of context of this. If you think about this little koala following the fires that happened in Australia, if you kind of decontextualise that, then you might say, you know, this youngster's a mental health problem, but we really need to look at this in perspective. And this quote from Angie Masters is really important to me, because she says that I think one of the most important things I would change if I could would be an acknowledgement from the medical profession that what we do to these tiny babies will affect them for the rest of their lives. So I started to think, why do we have this increased prevalence of post-traumatic stress disorder, anxiety and depression in CHD? And trying to disentangle that, you can see that there is what I kind of think of as the perfect storm. So you have exposure to trauma, so lifelong exposure to trauma, so that includes paediatric intensive care as an adult, surgeries, A&E, medical interventions, cardiac events and devices, facing transplant potentially, facing an uncertain prognosis and threat to life. We know there is this increased mental health kind of aspect, but we also know that there's a lack of screening or adequate support. We also know in terms of mental health problems that one of the kind of risk factors is feeling powerless. And as a patient, there are many things that contribute to that. So disempowering aspects of care, such as being in the patient role, hospital gowns, clinical holding, waiting times, medical uncertainty, and poor adult care provision. We also know that our mental health can increase risk if there are other background life kind of stressors. And we know that with CHD, we can face increased mortality and morbidity burden. There may be physical limitations related to your condition. There's also the impact on education, careers, finances and relationships, and issues having and raising a family. And we also know that the most protective factor for good mental health is social support. While this population may kind of face disruptions to attachment in early life, also parental mental health may be affected by having a sick baby. Feeling different, scarring, body image, bullying, ableism and discrimination may also present barriers to accessing social support. It's not all of a bleak picture. It's important to remember that many people do not develop PTSD following traumatic life events. Although we do understand now that our window of tolerance for detecting threat is often narrowed by early adversity, or what's commonly termed adverse childhood experiences. So we might have a kind of smaller window of tolerance before we kind of flip into perceived threat or kind of hyper or hypoarousal. Many people also report positive adaptation, however, following early adversity. That can include increased resilience, a deeper appreciation of life, closer relationships, increased empathy and personal strength. It's important to note that mental health difficulties and positive adaptation aren't mutually exclusive. You can have both, and often that kind of positive adaptation can mask the trauma, underlying trauma. So what I've started to think about is how can we mitigate risk factors and promote positive adaptation for this population? And this is where the what I've termed psychologically informed medicine comes into play. So this is an article I had published in the Journal of Health Psychology back in 2020. And thinking about the different areas that we could focus on within medicine would include creating a more healing environment within the medical setting. So less clinical, more healing, more holistic, that's trauma informed. Also addressing disempowering aspects of care, promoting social support and inclusion, looking at post-traumatic growth and how we can use this to help people build resilience and deal with adversity, embedding psychologists within the team, and also supporting our healthcare providers through reflective practice and making sure that they are also supported in terms of their emotional and psychological health, because it is very difficult work that they're doing. So the first part of this that I want to talk about is some work I was involved in where we looked at the impact of the hospital gown on patient wellbeing. And this very much came about through personal experience of having to wear this hospital gown lifelong, and it being at points of my most vulnerable, and then being asked to kind of don something that was very revealing and actually just made me feel like, you know, could I be asked to wear anything worse at this point? So I completed this with Dr. Nicola Cogan at Strathclyde University and Manos Georgiadis, who is at the University of Suffolk, and some students that we had at the University of Strathclyde. And it was a multi-methods approach. So we did 10 interviews, in-depth interviews with people with congenital heart disease, asking them about their experiences of wearing the hospital gown. And we also followed that up with an online survey, which was completed by almost 1,000 people. So it shows you kind of how much of an issue this was for people. So in terms of the online survey, 64% of people reported they struggled to put the gown on. 41% noted that they had to wear, they were offered two, so one the other way around to kind of conceal their dignity. 70% reported it didn't fit, 58% felt it limited their activity. 60% reported wearing it even though they felt like medically it wasn't necessary, and 70% felt it influenced how they saw themselves, so kind of how they felt about themselves. It was associated with feeling exposed, self-conscious, vulnerable, cold, embarrassed, disempowered, and that was exacerbated in the female population and also people with long-term conditions. In terms of the interviews, we conducted thematic analysis, and we found that there was really three main themes associated with wearing the gown. These were symbolic embodiment of the sick role. So people described kind of losing their healthy identity as soon as they started to wear the gown. So we've got one quote there as an example. So they said, as soon as they take it off, just like you dehumanize me, I don't feel like me anymore. Our participants also reported emotional and physical vulnerability. So they felt cold, exposed, and that the gown just wasn't fit for purpose. And a quote was, it takes us back to them places as a child. Your mum walking out, leaving you, the abandonment feelings, the feeling fear and anxiety and pain, because you remember having the clothing and having blood taken or getting physically held down or held back. And finally, the other theme was relinquishing control to medical professionals. So people felt as soon as they put the gown on, they kind of were handing control over. And there was this sense of passive acceptance and disempowerment. So the quote there was, it's all part of the whole process of not being in control, not being able to wear your own clothes, not being able to do what you want, and then having to let the medical team take control. So we actually won an award for this through the University of Strathclyde Images of Research. And this was through a selfie that I had taken of myself in the gown. And quite fittingly, this image was then displayed as part of an exhibition for a year at the Scottish Exhibition Centre, which was quite meaningful for me because I don't know if you can see, but across the River Clyde there is York Hill Hospital, where I had all my paediatric surgeries. So that article is open access and it's been published in the journal, British Journal of Health Psychology, if you want to access that. So the other thing that I've been working on is, if you think about psychologically informed medicine, one way to mitigate trauma is to improve feelings of safety. So this is embedded within Stephen Porges' polyvagal theory, which offers a science of safety, and it really revolutionises our understanding of trauma. Through a polyvagal lens, we can better understand why people feel safe, and that can help us to prevent post-traumatic stress, promote well-being and resilience, and post-traumatic growth. However, we don't have any way to measure psychological safety. That doesn't exist at the moment, and this is something that I got in touch with Steve Porges about. And what we did was we set about developing a way to measure psychological safety, to assist with clinical work and also facilitate research to try and improve this. And we've been doing this for the last 2 years. So again, I've been working on this with Dr. Nicola Cogan at Strathclyde University and some of our students, including Callum Calderwood and Marek Nikolak, and other stakeholders, expert stakeholders who work clinically within trauma. And Professor Porges' postdoc, Jacek Kolaks, who has been really instrumental in this as well. And they're at the Kinsey Institute at Indiana University, Traumatic Stress Research Consortium. And you can see a preliminary psychological safety measure here. So we're in the process of validating the psychometric properties of this. So it's not quite ready to go out there. But what we hope is that people will be able to use this measure once it's been psychometrically validated in whatever circumstance they want to measure psychological safety. So for example, a question might be, how did you feel during your hospital appointment? And then you could ask patients how they felt and assess how safe they felt and kind of adjust things accordingly. So building on that, obviously the COVID pandemic then happened, and I've been very aware of the fact that this has intensified health inequalities. The most vulnerable people do face the greatest impact of the pandemic, physically, psychologically, economically and socially. People across the lifespan live with underlying health conditions. Well, you might not think that if you listen to the media. And we know that up to 3.5 times risk of death involving COVID for people with a disability. There's also been data to suggest an increased risk of serious complications for people with complex congenital heart disease, and many have been advised to socially shield or vigilantly socially distance. About half of adults in the UK who do have an underlying health condition report that their well-being has been affected. Anxiety levels are higher, and disabled adults are more concerned about the future. And we have this widening gap in income. So there's this negative mental health impact of quarantine and shielding as well. And one study that came out recently reports disruption to cardiac care during the pandemic, concerns about infection and high levels of psychological distress in the CHD population. So these are just three articles that I've had published. 2 were blogs in the British Medical Journal and 1 was in the Herald about this issue. The most recent one was about patient waiting and how this may have been already, was a concern and may now be increased for people with underlying health conditions due to the pandemic. Another thing that's become very apparent is that the COVID-19 pandemic, has the potential to fuel discrimination, ableism and health privilege. And you may have noticed some of the headlines. So there's been a lack of general understanding, I think, that people across the lifespan live with underlying health conditions. Very often it's assumed that these are older adults who are maybe already receiving a pension, who don't work, when in reality there are lots of younger adults with serious health conditions who may be parents, who have to worry about paying bills, who have to worry about going to work, and what impact this might have. So what we have done is an exploration into the impact of the pandemic on the mental health of adults with congenital heart disease. Again, this was with our colleagues at the Kinsey Institute, so Professor Porges and in particular Jacek, and Callum Calderwood and Claire Murphy, who are both students at Strathclyde, have helped us with this too. So again, this was in collaboration with Dr. Nicola Cogan. And our charity partner was the Somerville Foundation, and we were interested in exploring the impact of COVID-19 on people with congenital heart disease. But we were also interested in learning from this population, because this is a population who are used to medical uncertainty, they're used to having periods of ill health. So we were interested in what this population can teach us about coping with adversity. So I don't really have time to go into this in much detail. However, you can see that we had 236 people completed the study, average age 43, mostly females. 38% had been advised to shield, but 55% were actually shielding. So quite a few people had decided to do that themselves anyway. And most were under the care of a specialist congenital cardiology service. So we completed several multiple linear regression models, and we were interested particularly in the impact of kind of mental health and positive adaptation. And what we found was, doing those regression analyses, we found that they suggested there was an importance of fostering healthy emotional regulation for post-traumatic growth, and that was to do with appreciation and strength. So that's what seemed to be linked with post-traumatic growth, was having healthy emotional regulation. Emotional regulation is the ability to monitor, evaluate and modify our emotions. That's fundamental to everyday functioning. It's being aware of our emotions, being able to tolerate unpleasant emotions, being able to identify them and recognise any patterns and having that insight. We also did a screening measure for PTSD, and this came out at 30%. So that suggests high levels that's consistent with previous research, and that might be being, and is likely being exacerbated by the current pandemic. So in conclusion, we again recommend a growth-focused, psychologically trauma-informed approach to medicine and public health that supports mental health and living well. These are just some of the quotes as well. So we've not completed this yet, but we're also doing a thematic analysis because we asked a couple of questions at the end. One was just kind of an open question, and another one was about media coverage in particular. So people said things like, it's made me more aware of my health condition. I'm worried more about the lack of medical care in an emergency than the virus. Being in the shielding group, I feel like we've been forgotten. I feel like I'm in prison for a crime I didn't commit. And it feels like people with underlying health conditions are to blame for their increased risk. Like the condition is their fault and they're unimportant. So the next section I was just going to cover is some activism work that I've been involved in. So I guess about influencing policy, trying to get a seat at the table and then trying to keep it. So back in 2012, I submitted a petition to the Scottish Parliament asking for improved care and healthcare standards for the congenital heart disease population. And this was following several life-threatening incidents with my own care. This was, I didn't realise it was being recorded at the time, but it ended up being reported on the BBC and STV News and the Holyrood magazine. And from there, I was invited to be a Scottish campaign manager voluntarily for the Somerville Foundation. So the Somerville Foundation is the leading heart charity for adults who have had a heart condition from birth. And it was a very steep learning curve, but learned how to become an activist. So I joined relevant cross-party groups, lobbied MSPs to submit parliamentary questions, very much used social media as well, which has been a great asset. And we ended up getting an NHS network for congenital heart disease and consequently the Scottish Congenital Cardiac Advisory Board. And following a lot of input and work, eventually the NHS Scotland did issue specialist adult and paediatric standards for congenital heart disease back in January 2018. So this was a huge step forward. It was the first time we had healthcare standards for this population. And this was for the national service, so we're still working on local standards because health boards, local care is tasked to each local health board, so they have to be created separately. And Healthcare Improvement Scotland are doing this piece of work. Unfortunately, it's been put on hold because of COVID, but I do sit on the working group developing these standards as well. And I also sit on the Scottish Obstetric Cardiac Network, which is led by the wonderful Maggie Simpson, and they're doing a lot of amazing work as well to try and address the fact that maternal death due to cardiac conditions is abnormally high in Scotland. So just in terms of policy documents, we do now have, as I mentioned, the adult standards and paediatric standards for the local service, for the national service. And the Scottish Government just released this heart disease action plan, and I was delighted to see within that there was mention of psychologically informed heart failure care from a talk that I gave at the University of Strathclyde. I was invited by cardiologist Claire Murphy, and there's also mention of psychosocial support needs that are mentioned within the standards. So I've always tried to make sure that psychological support is embedded within any standards that are produced. So we now have 5 specialist congenital cardiologists at the specialist service, 4.2 full-time equivalent nurses. Psychologists is stated in the standards, but it's still not funded, so that's still an ongoing fight, and rehab remains poor. And as I mentioned, we're still working on the local standards, so some progress, significant progress, but still very much a work in progress and lots to do. Something else I wanted to mention was ableism. So very recently, and this kind of has come about from my own experiences again, I started to think about my own journey and my own career, and how many of the restrictions have been caused by my health, and how many have been caused by the structures out with that. And while disability is a very common experience, it's rarely discussed in psychology, and this has become more and more apparent to me. We are underrepresented professionally, so less than 4% of academics and less than 3% of practitioner psychology workforces have a disability. People with kind of health conditions and disabilities do share disadvantages with other minority groups. So there are disparities in civil rights, discrimination, income, education, employment, and we're underrepresented in media and politics. And a range of studies have demonstrated a negative impact of congenital heart disease on education, attainment, and employment. So for example, one study reported that compared to healthy adults, even amongst the healthiest adults with CHD, there are significant decrements in life expectancy, employment, and if you look at lifetime earnings. And again, this was published in The Psychologist and it's open access, so if you're interested in that, please take a look. So in terms of inclusion, this was a project I was involved with two friends of mine who also happened to be born with a heart condition, Caroline Wilson, who is a journalist, and Jenny Kumar, who runs a PR consultancy business. And the three of us got together to try and increase awareness about this population that is hidden in plain sight, but also to try to kind of normalise having scars and yeah, to try and highlight. And we had these huge kind of 6-foot posters of models of people who have a heart condition, adults. And this was exhibited at Kelvin Grove Museum and Art Gallery back in 2015 for a month in the Central Hall. And again, we got huge media coverage for this, so it was a really great event. And we then, following Kelvin Grove, it toured around the Scottish Parliament, Royal College of Surgeons and Physicians. It was at British Heart Foundation conference, and Forth Valley Royal Hospital, and also at the Golden Jubilee, which is the home of the Congenital Heart Service. So that was just a way to try and kind of promote wider awareness. And that's something that I try very much to do. So I think Cameron mentioned at the start about how we know so much in psychology, and I think that we do. I think things have come a long way from when I was a child and when there just wasn't psychological support. I think we know a lot better now, but we're not very good at sharing that as much outside psychology, and that's something that's very important to me. So I try to publish as widely as possible. So in addition to the psychology community, I try to engage policymakers, the medical community, people with lived experience as well, to empower them with the knowledge that can help, and also the public through kind of mainstream media. And I do a lot of this through by being very active on social media as well. I don't know if this will play, but I'll try to play it. But this was just 2 weeks ago. I asked a question, managed to get on BBC Debate Night as well. Oops. See if it works.
The sound I don't think is playing.
Okay.
Might have to like unshare and reshare maybe.
Right, I'll just leave it just now. It was playing on mine, but that's fine. It was just asked a question about psychologically whether or not the pandemic would mean that there was a better understanding of the link between psychological and physical health, because there's been quite a lot of talk about long COVID and the impact that has psychologically, which is good and opens up, I think, some conversations there about the psychological impact of long-term health conditions. There's also been a lot more conversations about the psychological impact on healthcare providers, which is great as well. And Nicola Cogan and I have been delivering webinars to healthcare workers through Unison, and that's come up a lot. So really kind of looking at the psychological impact of medicine on both patients and also healthcare professionals. So something else that I think is really important in all of this work, just to see, is collaboration. So I have been so fortunate to work with many brilliant, inspiring minds. I think if there's one thing I'm good at, it's collecting people and keeping them in my life who, you know, have really helped me to develop ideas and give opportunities to work on them. And you know, I can't mention all of those people today because there's far too many. But I do sit on the Division of Counselling Psychology committee in Scotland. I'm an affiliate at the University of Glasgow. I also work with, as I said, people at the University of Suffolk. More recently, I've been involved in some amazing work by Professor Lucy Bray, who is a professor in children's nursing, and she has she's developed an international group. And what we're doing is looking at developing rights-based standards for clinical holding. So children who are held clinically for medical procedures and held down. So we're developing international standards, and there's a huge collective there to try and kind of bring children's rights into that. I also sit on the Scottish Congenital Cardiac Advisory Board and the Scottish Obstetric Cardiac Network, and lots of amazing people in these as well, and Health and Care Improvement Scotland. And yeah, lots of amazing people at the Somerville Foundation as well. It's a very small charity that punches well above its weight. But also I'm a Healthcare Professional Alliance member of the British Heart Foundation as well, and work with them too, and the Alliance, and lots of other places that I've probably missed. So just to come back to where we started, if we think about psychologically informed medicine, I think about how do all these different bits fit. So there is a kind of strategy in my mind trying to work on these different areas. So in terms of addressing disempowering aspects of care, that's where the work on looking at mental health impact of wearing gowns, also the clinical holding work, and then the kind of more recent article looking at waiting across the patient journey. In terms of promoting social support and inclusion, trying to very much advocate for the soothing presence of the caregiver, being there during the hospital experience, which is really important. But also trying to engage politicians, the public, the media, to try and promote wider awareness so that we can have broader social inclusion through things like the Scarred for Life exhibition, and also trying to tackle ableism. Post-traumatic growth, so our study looking at the psychological impact of COVID-19, what we focused there was looking at what facilitates post-traumatic growth, and what came out was emotional regulation, and that could help to inform, you know, what we should be doing, you know, right from infancy in terms of trying to help people of in this population and other health populations build resilience and deal with the adversity that we can't do anything about. Also, I'd really advocate for embedding psychologists within the team to support both the patients, but also to provide supervision and support for healthcare professionals. And as such, it's about getting that embedded within the standards and making sure that there's adequate resourcing for that. And that ties into the next one about reflective practice to support healthcare professionals. And also trying to kind of make a cultural shift so that we have a trauma-informed, more healing environment. So we're looking at things like how noisy wards are, we're looking at things like kind of safety, but at the moment we don't have a way to measure that. So what comes into that is developing a way to measure psychological safety, because once we have that, we can start to look at how we can improve that. So just kind of finally, just to don't lose sight of your focus. And for me, that is quite clear. So I do think I have a unique insight into what it means to live with a serious medical condition from cradle to grave, having experienced invasive, painful experimental procedures from birth. While I make the most of the life I've been gifted, it does impact every facet. So relationships, education, employment, finances, parenting. And I very much felt and witnessed in other children that I've seen in hospital and on my ward, a lack of psychological support and many barriers to inclusion. My professional and personal journey has helped me to understand my own experiences and to create meaning from trauma. I think as medicine advances, there is a growing population of people who have lifelong medical conditions. We really need a psychologically informed approach to healthcare and policy to promote inclusion, to tackle ableism across the lifespan. So these are just some articles I've had published relevant to this over the last 6 years or so. All of them are on my website. And yeah, this is just some of my team here who, obviously my team is a lot broader than this, but these are the kind of main people who are behind me throughout all of this, and who have been kind of subjected to the trauma along with me. So my husband and son and my mum there, who's had to put up with this since I was born, and my wee doggy. But I would just invite any thoughts and reflections, and I'm happy to answer any questions.
That's great. Thank you.